Alrighty, everyone. Well, thank you guys for spending your 8 o'clock at night here with us tonight. I am going to be filling in for Ben Keaton, who's usually leading our residency Hot Topics. My name is Phil Forsyth. I am an SCS graduate and current faculty member of our sports residency here at the Jackson Clinics, and I'll be stepping in to the host of the absence of Ben tonight. It is going to be my pleasure to introduce my former professor and mentor at the University of Pitt, Rick Joreitz, for a talk on all things isometrics tonight. I'm going to get you a quick rundown on Rick here, and then he'll dig right into our topic for tonight. So Rick earned a Bachelor of Science in Rehab Sciences with a concentration in AT and his doctorate of PT at the University of Pittsburgh. In 2011, he did become a board-certified specialist of sports by the American Board of Physical Therapy Specialties. He's worked as a physical therapist for the UPMC Rehab Institute, also formerly known as the Centers for Rehab Services, for 11 years. He was the team physical therapist for the Pittsburgh Penguins, including their 2016 and 2017 Stanley Cup championship seasons. In 2019, he was hired to a dual role as our assistant professor in the Department of PT and the team physical therapist for Pitt Athletics, specifically the D1 football team. He is currently teaching the curriculum of musculoskeletal and primarily works as the head therapist for the D1 team in his off time. In 2022, with the support of the athletic department, he developed the University of Pittsburgh D1 Sports Physical Therapy Fellowship and serves as its current director. And he's also recently enrolled in a University of Pittsburgh Doctorate of Education program to continue furthering his academic career. Rick, I'm going to turn it over to you, and thank you for speaking to us tonight.
Yeah, thanks, Phil. Thanks for inviting me. Looking forward to it. Yeah, thanks everybody for joining on a late night here. So we'll get rolling. So I'm going to talk, just how to implement isometrics in our practice. I think there's a lot of new information that's come out, and I think it can really help the way we treat our patients. So just got a couple of goals and objectives for tonight, just reviewing the basic function of what isometrics are, the benefits of using isometrics in our rehab, and then introducing or discussing different types of isometrics, and specifically how to incorporate them in rehab. And I was thinking as I was preparing this presentation, for mostly like sports residents and younger clinicians and even older clinicians, you go through this spectrum of, novice, you're a third year, you just graduated, you're new to the whole work thing. And we're all trying to be experts in our career, right? We all have that mentor, that professor, somebody that we look up to that we think like, that's who I want to be like when I treat. It takes like some 10 to 30 years to get there. So first off, just kind of applauding everybody. Like it's Tuesday night at 8 o'clock and we're going to get on for an hour and talk something as basic as isometrics. But like, these are the activities that get us to be like moving towards that expert clinician. So I'm going to start it off with some audience participation. So first off, this is a safe place. So throw your answers in the chat. When and or why do you implement isometrics in your rehab? So if you could throw it in the chat, I've got it pulled up here on my other screen. If you don't want your name associated with it, just send me a private message and I'll just kind of read it out loud. So I'll give everybody a couple seconds here. Yep, tendinopathy early and post-op knees, I would agree. Shoulders, yep. Pain reduction, yep. Neuromuscular rehab, pain control, joint stabilization, meniscus conservative care. Getting the knee extensor mechanism conditioned as early as possible in early ACL rehab. Yeah, moderate severity and irritability, nice. Tendon health, contract, relax, good. So we've got, we've got some good answers, and I agree with every single one of them. So just quick review. That scary kind of first semester of PT school thinking about this. Isometric contractions, just as a review, we got a muscle contraction where there's no change in range of motion. So we got a fixed joint position. all isotonics have that one moment of it, that isometric action. So if you think about, the bottom of a squat, when you transition from eccentric to concentric, there is that one moment that there is an isometric contraction. And as a reminder, if you're getting those, PTSD flashbacks of free body diagrams, this is when internal torque equals external torque. And isometric contractions can produce more force than concentric actions. So most often, we think about isometrics as muscle setting or stabilization exercises. So our quad sets and glute sets, they're low intensity. We want to decrease pain, decrease spasming, promote relaxation, blood circulation. Absolutely agree with all that, right? Stabilization exercises, so we can get co-contraction for stability. So I think somebody mentioned that in the chat there. So if we're doing early rhythmic staves with a post-op shoulder, that co-contraction, that quick reaction from internal to external rotation, we're creating stability in the joint, holding the squat at the bottom. So you're getting that co-contraction of quads and hamstrings. So we're stabilizing the knee, creating that joint stability in a certain position, not necessarily relying so much on our static stabilizers. Benefits on pain. So pretty conclusive evidence that isometrics are going to reduce pressure pain thresholds in healthy individuals. You get immediate pain relief with those higher intense contractions. So longer hold times, higher intensities, a lot of those Rio studies that are out, kind of a caveat, keep this in the back of your head. This is, in both of their studies, low number of participants, and they all had a tendinopathy. So it is a specific group. But that being said, even though it was a low number, if they were all the participants were in-season athletes. So if I can do some sort of a dynamic exercise with an in-season athlete and get pain relief, I'm absolutely doing it. But I don't know if I can apply that principle to everyone, right? So questions with this, like, is this going to save the field of PT? I don't know. I think it's a good option. I think it's a great warm up. Modalities, for what they do, they're there for pain relief, and there's a time and place for modalities, and I'll use them. But if I have the choice to do a dynamic warm up that includes isometrics prior to a rehab or a training or a field session, I'm always going to choose that over heat and stim, right? It's not a question for me. And can we implement this strategy? Yeah, we can fit this in. So maybe instead of the bike for a warm up, we're doing a couple different exercises that include isometrics, and now we're getting that, turn the muscles on, high intensity contractions, getting immediate pain relief that lasts, 30 to 60 minutes. So the benefits on tendons specifically. So injured tendons are not as stiff and they're thicker compared to healthy tendons, and exercise increases healthy thickness and stiffness. So kind of what the unhealthy versus healthy thickness is, I think that's a conversation for a different time. But the research does conclusively show that isometrics will increase cross-sectional area and stiffness in tendons. So better increases in stiffness with the higher intensity contractions, less with the lower intensity ones. Longer hold times compared to shorter hold times, increased stiffness. And then, not conclusive, but for the most part, isometrics do a better job at increasing that stiffness compared to isotonics. So depending on who and what you're treating, this may be the better option. And then when pain allows, when the patient allows, you want to aim for those higher intensities. And we'll kind of get into further reasons as to why moving forward. A lot of the research used to show that there was this angle where isometrics specifically had their effect on. And now there's controversial evidence. So a lot of research will show that kind of where and what angle you do the isometric, that's where the changes occurred. That's where the strength increases occurred, kind of post-intervention. And then some studies will show no, if you do it in some positions, you're going to get a broad range of positive effects. So the question becomes, is the intervention, is it the isometrics or is it the neural adaptations that's causing this strength increase? Probably not sure. But how does that play into our decision making on a day-to-day basis? So if I choose a knee extension isometric at 45 or 60, like I know if I choose that, that's kind of mid-range. It's a good length tension relationship for the quad, so I'm going to get a high output as it is. It's a safe joint position, a lot of contact area with the patellofemoral joint. So now I'm getting decreased joint reaction forces. I can choose the angle that's pain-free. So if it hurts here, don't do it. If it doesn't hurt at this angle, do it there, right? Not rocket science. And then kind of another option would be choosing the angle, like here's where I'm weak. So if I do various testing, whether it's isometric or isokinetic, if I find I'm weak in terminal extension or at the bottom of my lunge, right? That's where I want to employ my isometrics. I want to address the weakness at the location where I'm kind of demonstrating that weakness. So this study, just want to point out to look at specifically at the joint angle. So they did pre and post strength quad testing at, there was a lot of angles here, 35, 50, 65, 80, and 95 degrees of knee flexion. The isometric group did isos at 65 degrees for 4 weeks, and then the control group they kind of did their thing. And the results were that there was increased max voluntary torque at 65 degrees. That was where the most amount of torque increases occurred. And then the next two largest increases were at both adjacent angles. So at 50 and at 80, right? Right off the bat, just looking at these bullets, it's obviously, it's not a great study, right? There's an intervention group of isometrics that increased torque production, but they didn't really compare against a different form of strengthening. They just had a control group doing their own thing. But it does show the results that the strength gains, at or near the training angle. So again, reinforcing, performing the training at a specific angle versus a random one. So why do we care? Like we're choosing, there's a reason why we're choosing the position that we perform these isometrics in. And this study is reinforcing that. So I can choose, if I want to do it at mid-range or a shortened position or a lengthened position, there is a reason why. It's not working. Why won't you work? There we go. So can we increase strength with isometrics? Yes, we can. Evidence is going to show that the intensity of the contraction needs to be probably greater than 60% of our MVIC. It's inversely related to duration of the contraction. So our max effort isos, we can't hold it that long. We can hold a submax isometric for a lot longer. Kind of deciding what you want to do. Do we want that max effort or we want longer hold times? That's for you to decide. What's kind of in researching more for this presentation, I found it interesting that there was a lot of evidence showing that there's a higher hypertrophy effect when you're performing these isometrics in our lengthened or stretched positions. So, maybe if we're doing these knee extension isometrics in, let's say 60, 75 or 90 degrees of flexion, or even greater than 90, what would happen if we lean back at the hip, right? And, it's rectus is going to be a 2-joint muscle. So if we can affect the hip, maybe we're putting the quads on even more of that stretch and we're going to get a better hypertrophy effect. I found that interesting, kind of like in researching this. So it's definitely something that I want to employ with early post-ops moving forward. So kind of a question for the group, and if you want to throw it out in the chat or say it out loud, when do you stop prescribing quad sets after knee surgeries? All right, no takers. So I'll throw out, there's one. Once no extension with no extension lag with a straight leg raise, probably around 4 to 6 weeks. Good answer. So, that kind of threw in, when they can complete higher level activities with the same success rate, short arcs, long arcs, or isometrics at different angles, full engagement at fast speed. Yeah, all good answers. So I like, and this was perfect because I was hoping for, there's a a functional performance element in that question, and then there was some answers related to time. So if you've resolved the lag, right, is the quad set getting you stronger? Right, so something to think about. So another one came in, VMO fires adequately with no lag. Again, so we got a functional performance dictating like, all right, let's move on. So again, you're thinking about what's the quad set doing? Why are you prescribing that exercise? Right? If we're all sitting there like, all right, I got to get these quads stronger. Is the quad set going to get you there once the lag is resolved? Right. So I would argue there's probably some better options. And we'll go over those. So how do we implement these isometrics? So these may be new terms for you, or you may be very familiar with those. I've probably learned about them in the past 6 months, and really started implementing them. And I can tell you, like they do make a lot of positive changes in my rehab. So this first type of isometric, it's called a pushing isometric muscle action, or a PIMA. It's also known as an overcoming isometric, and you're essentially just pushing against an object. You're attempting to perform a concentric action. So think about, I'm doing shoulder external rotation isometrics in a doorway, pushing into a pad, and I'm trying to knock over a wall, right? I'm trying to just push through an immovable object. So it's a pushing isometric, right? The other type is a holding isometric muscle action, or a HEMA, but this is kind of better known as a yielding isometric. This type is holding a position against a specific load, which is most often gravity and an external load, and you're looking to resist an eccentric action, right? These are quicker to fatigue. So an example would be if I'm sideline trying to perform external rotation, and I'm going to external rotate my arm up to neutral, and I'm going to hold it there for 30 seconds. So whether or not I have a weight in my hand doesn't really matter. I'm holding at least against gravity for 30 seconds, just trying to fight through that position. Okay. So implementing these pushing isos. So whatever exercise you're going to do, you're going to set them up, and you can use RPE, an inline dynamometer, and force plates to gauge percent effort, so you can get an objective number, or you can get a subjective, I'm pushing like 8 out of 10, or I may be pushing as hard as I can, and the inline dynamometer is telling me that I'm pushing like 20% of my max. So it's like both those pieces of information are good to know, right? And the question will be, are you ramping up or kind of blasting through this isometric, right? And we'll talk more about RFD later, but how you cue them will be a little different, right? So a couple of examples. In the left picture here, we've got a plantar flexion isometric in a lengthened position. So the foot is positioned in max dorsiflexion, and we're pushing as hard as we can for X number of seconds into plantar flexion. So we got that plantar flexion iso in a lengthened position, right? Kind of a very standard use of an inline dynamometer. This is a tin deck, and strap them onto a table, and we're doing isometrics here. Don't look, this is not the position I use for testing, because this table is not nearly stable enough, but it is a very quick and easy setup for doing exercises. So I can do my isometrics, and I can use the tin deck and get live feedback for how much force is being created. And then the picture on the right is just a single leg isometric push. So the leg press is locked, and on cue, they're just pushing as hard as they can, and they've got to hold it for the set number of seconds that we're prescribing that day. Okay, implementing yielding isometrics. So our holding isometrics. So same thing, set up your exercise, decide what you're doing, put them in the position. A couple of difficulties with this. You have to choose your load, and you're going to do usually a percentage of whatever exercise you're doing at a specific position. So an example would be, if I'm doing a single leg press or a squat, I'm going to hold it at the bottom or at some position that I decide upon for X number of seconds with Y percentage of weight. right? So that number is, we're tracking that. And with those numbers, there's less of a linear progression, right? So if they accomplish the exercise, if they do well with it, do I progress the time held with the same amount of load, or do I progress the load with the same amount of time? Do I progress both? All good answers, but it's not the most straightforward process, which in the same breath, because it's not a straightforward process, it opens up a lot of doors for creativity, and that's kind of a good thing, right? Um, Motion is going to occur when they fail. So you have to decide based on who you're treating, what you're treating, is that okay? So if that leg falls, that arm falls, if you move out of that position, are they going into a safe position, or are they going to collapse and potentially get hurt? You have to decide that, and obviously safety is going to be your primary concern with the rehab. um, these are, I don't know if better is the right word, but because I can't think of a different word right now, we're going to go with better. These are probably better when those athletes are returning to activities that require the deceleration and eccentric control, because you're looking to fight through that collapse of a position, or you're looking to prevent that eccentric muscle action with that. So a couple examples are, here's a standing plantar flexion. The guy's holding a dumbbell there, so he's looking to hold that heel height up as high as he can, let's say for 20 seconds, right? Here's a wall sit with the heels elevated, so we're trying to maximize the amount of quad force that we're implementing with this exercise. And then here is a knee extension, single leg. You got to hold it at terminal knee extension for X number of seconds. And we can decide, do we do a set number of seconds for how long you hold this rep, and then once you hit that time, let's say it's 30 seconds, and once the clock hits 30, all right, use the other leg, or drop the weight in the standing plantar flexion, or push yourself off the wall, or grab the weight with the right leg and let it go? Or do you say, go as long as you can, maybe not so much for the wall sit, but for the plantar flexion and the knee extension, go as long as you can. And as that heel drops down, as that knee starts to flex back towards 90, just fight through it the entire time, right? And now you introduce this element of competitiveness, and you're teaching that patient, and you can do this early, you're teaching that patient to fight through it, to keep pushing. It brings this element, especially if you're treating, the athletic population, you're introducing that element of competition, even in a very basic exercise, and the rehab session just becomes better. And I don't want to say sport specific, but just better geared towards athletes. So I touched on it earlier, creating rate of force development. We could spend a whole session on this, but just touching on this, isometrics really go hand in hand with plyos, because isometrics are helping to create that tendon stiffness, which is, the stiffer the tendon, the better those plyos are going to be. So we can pair isometrics with plyos. We can do something like a isometric squat and then pair it with box jumps. We can do plantar flexion isos and then go into hopping, iso bench press, and then do various med ball drills, and then standing ankle iso push, like in the picture here, and then kind of do this as a precursor before we start running on the field. So getting into, all right, so what's this look like, right? And so we're all sports physical therapists, so the only thing we treat is ACLs, right? So figure, just make a case on this post-op ACL reconstruction early on. Our goals, we want to establish a quiet knee, right? And I'm sure you've heard this a billion times in all of your education sessions. But if we really think about it, and especially kind of starting to think in that residency mindset, this is all one and the same, right? I can't do one without the other, right? They're all linked to each other. So I want to address quad function. I can't do that unless I have full extension, unless I have adequate patella mobility. I can't do that unless the pain is down and the swelling is decreasing or minimal. And vice versa. Like if my quad's not working, I'm going to stay in a lot amount of pain. I'm not going to be able to keep my extension. My patella is going to get stiff. So they all go hand in hand. So if we talk about the kind of the typical rehab, quote unquote, in the first 2 weeks, your standard therapist, probably doing 3 sets of 10 quad sets, and then maybe they go crazy and they do 4 sets of 10 of straight leg raises, and then they add in NMES, whether that's in isolation or superimposed. But we're looking for that big milestone of performing a straight leg raise without a lag, right? It was kind of mentioned already in the previous questions. And what that means is that the quad, by definition, is now a 3 out of 5 manual muscle test, right? So I can go through the full range of motion against gravity. Okay, so that's my definition of a 3 out of 5. So we talked about the quad sets earlier. Like when would we discharge them? When would we keep doing them? So how do we make them more effective, right? If you say anything related to decreasing your AMI, always a good answer. But questions to kind of improve the efficiency of the quad set. Did you say anything? Did you cue the intensity of the quad set with your patient? Did you say anything at all? Did you tell them you have to squeeze hard enough to make sure that you get a superior patella glide? Did you tell them, I want you to squeeze as hard as you absolutely can with every single rep, or anything in between, right? Did you superimpose it with NMES? Did you change the angle? So if you look at the picture on the left there, here's just a patient who's sitting on the couch, and you can use the other leg, and now I can do quad isometrics in a more flexed position, which is probably more comfortable for them. And I can really build, because I'm in more of a lengthened position, maybe I'm building more hypertrophy in this position. So, hint, I would use this as a great home exercise. So if you think about all of your patients that are sitting in class, during the school year, everybody who sits at work with an office job, like sitting, watching a movie, watching TV, if you do your isometrics just in this comfortable position, you don't have to you don't have to lie on the floor. So you could do this with somebody who's, 2, 3 weeks out easily, even 1 week if you're lucky, if they're moving quickly. Or can we kind of abandon those quad sets altogether and teach them to push, right? So I'm doing the exact same thing, but now the cue is that I'm getting them to push. So I can do this light band here on the right, and now I'm basically just doing a quad set. It's a terminal knee extension, short arc quad, whatever we want to call it. But I'm basically just doing a quad set, but now I'm getting them to push hard through some sort of resistance. And now, okay, get your foot up off the table. All right, now hold it for 3 seconds, 5 seconds, 10 seconds, and just build up that time. And then you can keep this pain free. Like this is just a light band. It basically works as an external cue to get them to kind of push through something. And then straight leg raises, are you still prescribing them once the lag is gone? I could go on a rant about this, but are you really strengthening the quad if you're not adding weight to the straight leg raise? And even if you do add weight, you're still just doing an isometric quad contraction. The hip flexor is doing all the work at that point. The quad is responsible for just maintaining that knee extension. So I have the weight of the limb, the resistance of gravity, and let's say you go crazy and add a 2-pound cuff weight on them. When I lift up, all I'm doing is just maintaining that isometric contraction. The motion of the leg raise, it's not really, if anything, the higher you lift, the easier it is on the quad because the moment arm changes. You're just this is just a hip flexor exercise, right? So the question becomes like, when do I abandon this, right? When do I just keep adding weight? Like, are you going to put 10 pounds on their ankle? Are you going to put more than that? Or are you going to say, like, let's just choose something else? Because I would argue if you just keep loading them with cuff weights and just adding resistance, you better be good at treating anterior hip pain, because that's all you're going to have with those patients. Or can we turn this into a yielding isometric? So I can do that same straight leg raise with maybe a 2-pound weight, and now I want you to hold it, maybe 4 to 6 inches off the table, and I want you to hold it for 10 seconds. I want you to hold it for 20, 30 seconds, even as long as you can. And now I'm just like, you're teaching them to fight, right? Or get away from that, which I would recommend, and just move right away to knee extensions. One of the primary issues that you're going to have after an ACL, or really, sorry, not or really. One of the main issues you're going to have with an ACL, with a bone patellar tendon or a quad tendon autograft, you're going to have that donor site morbidity. So we can start isometrics to promote that tendon healing right away. And the beauty of these isometrics is that pain is your guide, right? How hard you press is dictated by pain. So you can make these as pain-free as possible, just by how you educate your patient. So we want to build capacity with our pushing times. And a lot of patients, I'd love to really know why, but anecdotally, I could just, like, so many patients early on, they hate pushing against the pad, and you'll have less pain if you move the pad more proximally. But you may want to move to this, and they have the strength to do the exercise, but they hate pushing against the pad, and it just causes too much anterior knee pain. So if that occurs, you can just use a band, wrap it around the ankle, and tie it to one of the posts of the knee extension machine, and tell them to kick out to, let's say, 60, 45 degrees, whatever angle you want to go to, kick out against the band, and then just hold it there. And now you've turned it into a yielding isometric. And then as that pain comes down, and they'll be able to transition to pushing against the pad, and you'll get there, right? Progressing, that patient, and we've all had them, you're strong, like you do really well, but man, you've got this 1 or 2 degree lag that just won't go away. So maybe it's like, I can keep my knee straight, but I can't do a leg raise and maintain that like 2 degrees of hyperextension. And it's like, I'm lifting weight, I'm doing all the right things, but this like pesky 2 degrees is just pain in the ass. Really like this exercise. In the bottom picture, you can use like a half foam roller, or just a small towel roll. And for a home program, really like using, like, if they would take their right leg, kind of a figure 4 position, stick it underneath that left knee to use it as a fulcrum. And if you use this gait belt as it's immovable, right? It's way different than a band, but use the gait belt, strap them in, and just get them to push and do that pushing isometric in terminal knee extension. That's the weak part. That's where you want to train. This is a really good exercise for that. So then moving towards that hypertrophy phase, like we want some muscles here, right? So using these isometrics, we can do a single leg press, 20, 30 degrees of flexion, 40 to 60 degrees of flexion, play around with the positions. There's that wall sit again. So now we're looking for longer hold times, higher intense contractions, shooting for max effort. And we touched on rate of force development early. You can play around with, you're transitioning from that ramping up. I'm going to hold this contraction for, let's say, 20, 30 seconds, and I want you to build up into it. Or we're going to hold this contraction for 5 to 10 seconds. And when I say go, I want you to hit it. So I want you to push as hard and as fast as you can, which is the same exact cue that you're going to give when they're doing like force plate testing. So they're already familiar with this, how this works. I hear that cue, push as hard as you can, as fast as you can. I'm doing a very safe isometric push, but with that same cue. So when I hear it again for that counter movement jump, I'm ready to go. And then kind of last thing, like, this will be a big theme, like preparing to test. When I do that inline dynamometer strength test for a quad, when I do something like a mid thigh pull, when I'm testing and I'm looking to use the results to make a decision, the first time they do this should not be when they're tested. they need to be very familiar with how this feels and how to do it, right? So we can do a sub-max effort isometric mid thigh pull. We can work on sub-max knee extension pushes. So when we do the test, they know exactly what they're walking into. All right. So moving on to, we also treat shoulders. So, what's it look like when we've got a labral repair, early post-op restrictions, some range of motion restrictions, and then a 2 weeks clear to start active assisted range of motions, rhythmic stabs, and 5-way isos in the resting position. So again, kind of what's your cue when initiating this? Probably not starting day one telling somebody to push as hard as they can when they're 2 weeks out of a surgery. Probably not the best idea, right? So a lot of this will be turn it on, turn it off. So 5-way isometric, so internal and external rotation, flexion, extension, and abduction, all with the arm at the side. So we're in that comfortable position, but they can do muscle activation. So turn the muscle on, turn it off. If you push 1 pound of force or 1,000 pounds of force, I don't care as long as it's pain-free, right? It's day one. Let's not try to be a hero. You're just looking to introduce the exercise. So then moving forward, once they get the hang of it, now we want to build up that contraction time up to 10 plus seconds. So we're looking to ramp up. So from, when you get to 10 seconds, you should be at max effort, whatever that is, it's their perceived max. And then a couple ideas just to build that hypertrophy. Physio ball squeeze with elevation. So if you get one of those big physio balls and you stick your arms out and you just squeeze it as hard as you can, and you're just doing elevation, just lift it up over your head, so your arms are probably going up to about 90 to 100 degrees of flexion. If you maintain that squeeze, yeah, you're getting 10, 15 reps of shoulder flexion, not that hard, but you're going to feel this pretty quickly in your pecs, right? So this is an early way to get pec and subscap involvement in a different capacity. And then building just isometric holds, playing around with your treatment session or your treatment approach. You're doing the same exercises, but can you sneak in an iso hold followed by several reps and then doing multiple sets of this? So doing like a lower high row variation, getting away from the bands, which it's not enough. It's too easy. Whether it's a cable, a dumbbell, a machine, whatever, mixing in like a mid-range or an end-range scapular retraction, 10-second, squeeze those shoulder blades as hard as you can, and then bang out 15 reps, right? Floor press, a little tougher because you're already in a restricted range, but can you hold mid-range for 10 seconds and then go do 15 reps? Flies with a cable, careful with this one. I would stay away from a lengthened position, especially early on in those first couple of months. But if I can get in, a scapular plane and maybe I'm just pushing into horizontal adduction, and then I can complete flies for reps in a modified range, doing them on a floor. I wouldn't recommend early on doing that max effort horizontal adduction in a lengthened position because we're putting a lot of strain on that anterior shoulder. You don't want anything bad to happen. Flexion, scaption, abduction, holding it at 90 degrees and then doing your reps. And then internal and external rotation, you can use a band or a cable. And here you can do, hold it at your shorten range, your mid range, and or your lengthened positions, and then do your reps. So really we're doing the same exercises we kind of always do, but if you sneak in this isometric, it just adds this other layer of complexity and just makes it it raises the bar for that therex intervention that you're giving. And then you can do really the same things, but change it to a yielding isometric. So, the deltoid raises, prone external rotation, with a cable, internal and external rotation at 0, shrugs, rows, bench, like a lot of different variety that we can do. And then you can really mess them up and add BFR to it. Throw a cuff on them. And now let's play around with it. Let's do, let's say we're doing, abduction raises. I'm going to put BFR on 5 reps, hold each rep as long as you can, hopefully shooting that it's at least 30 to 60 seconds per rep, and then have a 30-second break. Do 5 of them, you're going to be gassed, right? So it's just you're still doing those basic effective exercises, but now you're just adding this layer to it that like you're going to see a lot of positive results. And then ASH test, if you're not familiar with this, highly recommend reading this study, and this should be kind of standard of care for your post-op shoulder assessments, especially contact athletes. Like for me, working football, I love this test with defensive players because it just simulates arm tackling so well. This is different, right? This test is different. This motion is different because we're so used to pushing away and working external rotation. And now there's this test that you're lying prone and you're pushing forward, like, with your arm all the way up in the max flexion, in that Y and T position. And now I'm coming in, right? And it's just a different motion. This test, just like all the other ones, performing this test should not be the first time that you perform this motion, especially when you're looking for a max contraction. So you can start I'm not at all saying practice the test, but you can practice the motion so that they're familiar with it when they get into that return to sport testing situation. All right, last case. Looking at just a basic lateral ankle sprain. Traditionally, this starts with isometrics. We're taught that this is the safe way to introduce like a Therex program, and which is accurate, right? But what's the difficulty with isotonics for posterior tib and peroneals? The problem is if I do a test, my posterior tib is weak, and then if you're not paying attention and you're doing kind of global inversion with a band, well, guaranteed your anterior tib is taken over. So you got to maintain that foot in plantar flexion. But the problem is if I push down and in, I'm recreating the exact same position that they most likely got injured in. So guaranteed that hurts, right? Especially acutely. And then peroneal, same thing. If I have any swelling in that lateral ankle, when I evert to work my peroneals, I'm just causing compression in that lateral joint, and it's going to cause pain, right? So maybe we should stick with the isometrics, right? Instead of just doing your basic boring kind of entry level PT isometrics where you're just looking to turn muscles on. Now it's like, all right, I'm doing that residency thing, right? I'm going to keep you in neutral. I'm going to utilize manual resistance. So if I want to do posterior tib, like I know that my cue is to get you to push down and in, to get that posterior tib to kick in. I can start working rate of force immediately. I can do dual tasking. So I can give you a math problem. If the result of the math question is even, then you're going to push into inversion. If it's odd, you're going to push into eversion. And now I'm getting dual tasking. We're getting rate of force development. So as soon as you figure out, what 3 + 1 is, it's even, posterior tib, boom, invert, hit it. You just add this layer of complexity right away in an acute ankle sprain, and they have the control. How hard they push is dictated by pain. So they're still in a good spot. Plantar flexors like this, you get these ankle sprains, like this is what we need to work on. If they don't have plantar flexor strength, and it's tough to measure, if they don't have plantar flexor strength, they can't run as well as they can. They don't have that pop. They don't have that cutting ability, that deceleration ability. They don't have it, right? So looking at what the Achilles and plantar flexors do, like over 12 times body weight, Achilles tendon forces with running. Big components for single leg hopping for distance and vertical hop, both the propulsion and the landing phase. So if you're using a band for the plantar flexors, that's not strengthening. I'll give it, that's a warm up. I'll allow that. But if you're doing that, that blue or black band and calling it strengthening, like that's just not it, because they're about to go run, which is 12 times their body weight, right? So can we get into, pushing and yielding isometrics. And now we're getting into that triple extension position right away. I can get that inside push and that outside push. That inside push, you're going to feel your peroneals kick in, even though you're doing plantar flexion. That outside push can really get those medial muscles. I'll cue them to push that big toe down into the ground, which is going to ensure you're going to feel it in your posterior tib and your FHL. So you're kind of getting a couple birds with one stone. Bias to soleus, so we can do seated and standing combinations. Yielding isometrics, just hold these positions as long as you can. You can do single leg, working, just driving up through end range plantar flexion, like get to the very top in that seated position. And then you're introducing that proprioceptive element, like you're standing. So you got to balance with it. Now it's two legs. Like it's hard. You're just learning to fight as hard as you can to keep that heel up off the ground. And then thinking about what we're going towards, like ankle sprains, like we're going to probably do some hop testing for return to sport tests, handheld dynamometers, force plates for plantar flexion iso pushes. So we can do single leg counter movement jumps on a force plate. So getting them to get used to just pushing as hard as they can. They're going to do better with those tests. And then just kind of wrapping it up. Isometrics, more than just quad sets and glute sets. There's a lot more in intensity that we can apply. And you can apply it in a very safe manner. You can control the position, you can control the intensity, a lot of creativity you can get with it, with the intensities and the time held. And then thinking about where are we going with this patient, with this athlete, like these are the tests that we're going to do. These are the positions and the motions. So if we get them familiar with it, chances are we're going to have a better outcome with the test. And then just kind of like, I talked to a lot of residents and fellows about this, just kind of learning early on to be that difference maker. You're obviously you're in these residency programs and you get so much information thrown at you, and it's just, okay, I learned something today, do I need to change my entire practice pattern tomorrow? Like, no, it's take a couple of things from today and how can you implement it? And it's nothing here tonight was groundbreaking, right? We're talking about isometrics, right? But just these little subtle differences I've watched, just even in my own practice in the past 4 to 6 months, like the effect is legitimate, right? So if you make these little tweaks, your Therex program can still be really effective and you're still hitting the basics really well. But now you're just adding this element that it's better, right? And now your outcomes are going to be better, right? So I'll get off my soapbox there. So thanks for letting me drone on for like 45 minutes here.
Rick, thank you for the talk there. And I hope, like you said, it kind of elevates that residency level thinking for a lot of people in this call, where you can kind of take a basic concept in PT and kind of just elevate it a little higher. So I think for both everyone here, an enlightening talk, and then hopefully some more people on the rewatch. So we've already had a couple questions kick off in the chat. So I'm just going to get you going through the chat there. And then as more people have any questions, we'll probably cut off around 9 or so.
Yeah.
So it looks like Jeanette had our first one there, I think in reference to kind of the straight leg raise part of the talk. So if you want to pick up from there.
What are my thoughts on doing straight leg raises in long sitting instead? Yeah, I typically always have them either supine or just kind of leaning back on their elbows. I think if you, especially early on, I think if you're in that seated like 80, 90 degrees of hip flexion, you're really shortening the rectus. And to be honest, with the AMI that's probably happening in your post-ops and your quad shuts down, I think the straight leg raise it's a big rectus femoris exercise. So I think if you shorten that the most, you're going to have a tough time. So I do recommend being in that long sitting position.
And then next up, we've got Catherine. Plyometric enhances performance because it increases velocity and power. Studies have shown isometric training fails to improve measures of athletic performance, even when increasing maximal strength. Can you explain or elaborate a little bit more on implementing isometric into plyometric training, when and how?
Yeah, great question. I think it's kind of an indirect pathway. I think the isometrics are shown to increase that tendon stiffness. The stiff tendons are going to help you a lot with those faster plyos, right? The stiffer that tendon is, the faster that force is transmitted, the better effect those plyos are. So you're right. I agree that the plyometric training is going to be what increases that max strength from the plyometric activity. You're going to get faster, right? Doing those plyos. The isos are there to help. One, you could probably get, the pain relief if we're talking about a case with tendinopathy. But I think the isos are going to be a great kind of warm up primer, helping to create that tendon stiffness, which is going to help the plyos, right? And then you're probably not doing plyos every day, right? So those isometrics can be a great option on the days in between.
Awesome. Looks like Grace here. Is there a time in your programming when you stop doing isometrics completely, or are they a pretty consistent part of your programming throughout the rehab, given the different utilizations that you talked about today?
I have probably changed that. I do some amount of isometrics throughout the whole thing. And now it's, the early post-ops are right. There's a big component of isometrics, but now we had just last week we had a couple post-op knees. They had to do 4 sets of 4. Hang on. Go down into a rear foot elevated split squat, hold it for 20 seconds, do 10 reps. Do that 4 times. That's 1 set. They had to do 4 sets. They died. So I'm mixing in isometrics to, they've got to hold this in the bottom of their rear foot elevated split squat. It's effective.
All right. I think you're out of this part of the game, but how do you generally bill isometrics, neuro-rehab, TE, or activity? And can you kind of provide an example of where you may or may not use those as part of a billing process?
I just did my billing ULearns for UPMC. I can answer this, Phil.
Okay, let's do it.
Isometrics, that is just a standard muscle contract. It depends on the exercise. If you're doing an exercise that has some level of neuromuscular control, you can bill it under their therapeutic activity neuromuscular reeducation. If we're talking isometrics in a machine, that's Therex.
All right. Steve Betke, another Pitt former alum here. Any research on yielding versus versus overcoming isos being better for tendon stiffness?
Not that I know of. I don't know if they would be compared.
Gonna have to dig into that ourselves.
It's a great project for Steve.
Yep, I agree. And then my personal question here. So do you see single leg isometrics as potentially a better entry point for, let's take ACLs, for example, for the quad, more specific muscle impairments than traditional double leg weight bearing counterparts, squatting, hinging, more from that like interregional, intraregional consideration post operatively? So do you feel like you would start more single leg first and then build back into the larger double leg pattern? Or do you still do a lot of double leg patterns and then get them to single leg as soon as they can handle that? Or both?
Um, in the so my practice, so full disclosure, my practice also depends on the current strength coach that I'm working with, right? So following a lot of like their principles, how they operate in the weight room. So currently the past 3 that I've had, we don't our guys don't squat on, so any post-op knee, they don't squat until they can do like a rear foot elevated split squat with the same amount of weight. So, and I get it, like you want to balance out any asymmetries before you get under a bar. Or I've had one coach that they want to get a bar right away and they'll just deal with the asymmetries as they come, and that dictates their weight progression. It's kind of like they're the professionals, right? It's their weight room. I see both points. I like the former better. So in answer to your question, I think I'm doing a lot of single leg iso stuff until the legs kind of balance out, and then I want to get double leg.
Okay. And then this will probably be our last question for tonight. So is there a difference in parameters for yielding versus overcoming isometrics when programming for improving tendon stiffness?
I think it would all be dependent on, so for the overcoming isos, are you looking to push as hard as you can for a certain time? Like I want to hit 20 seconds, I want to hit 30 or 45 seconds. Push as hard as you can for that entire time. So let's say it's a knee extension and you're connected to an inline dynamometer. You're going to push for 45 seconds, but you're going to watch that force output just drop over that time. Or do you want to do pushing, and I want to maintain the push at 80% of my MVIC and hold it as long as I can? I think both options are great. And I don't think the tendon is going to know any different. The tendon understands that load is being applied. How and how long and how intense, like, is probably not what the tendon is primarily concerned about. And then yielding, kind of same thing. Are we going with, are we looking to hit a certain time and then you can give up, or you go a max time? Like, I think it's just how you want to program it. I don't know if there's one that's necessarily better than the other. I think it's kind of what's your goal today.
All righty. Well, do you have any contact information if anyone wants to reach out with some further questions or clarifications?
Yeah, sure. I'll put my email in the chat here.
Perfect. All right. And thank you so much for your time tonight, Rick. I'm sure we all appreciated it. And thank you for contributing to our ongoing residency hot topics here. If anyone else has any questions, feel free to reach out to Rick or me to help get you guys organized. And thank you for your time tonight.
Thanks, Phil.